Hello and welcome to the Health Occupations and Long-Term Care Subcommittee meeting. We have two bills on our agenda today, SB 82, which we hope to vote on, and then House Bill 1032, which is just going to be a discussion. SB 82 is the cross-file to a bill that we passed. Lisa, can you give us an update on this? And everybody should have an amendment in their packet.
Yep. So Senate Bill 82 requires individuals to be licensed with the State Board of Examiners of Audiologists, hearing aid dispensers, and speech language pathologists by January 1st, 2022, in order to practice music therapy in the state. The amendments specify the representations to the public a licensed music therapist may make regarding communication disorders. And the amendments clarify that a music therapist may work with a client who has a communication disorder and address communication skills.
Excellent. And I know we have some stakeholders here on this bill. I see Nikki Runge, I think she says her name. I see Olaremi Dean, who is with the Audiology Board. I see Susan Adams, who is with the National Association of Speech Language Pathologists here. Is there anybody, any stakeholder who wants to speak on this amendment? Have you seen the language in advance? I'm not seeing any hands up. You can raise your hand if you feel that you... Okay, hold on, let me now. Okay, hold on, let me step back for a second. So we have a, I see Nikki's hand up, and I'll call on you in a second. I just wanna make sure that the committee has the full background on this amendment because they weren't part of a meeting that we had with the sponsor of the bill. So the backstory is that after we passed this bill originally, it came to our attention that we needed a clarifying amendment. We worked very diligently to try and find an amendment that would address the needs of the speech language pathologists without restricting the capacity of the music therapists to do their work. I know that the board met and they requested specific language in an amendment. This language is not exactly the specific language that the board approved. However, it is entirely in that spirit. It gets at solving the same problem of figuring out how the music therapists can continue to work with people who have communications disorders to help them address their communication disorder without infringing on the scope of practice of speech language pathologists. So that is the intent of the language that is similar to what the board asked us to do, but not the exact words that the board asked us to do. So with that, I see Nikki's hand up. So do you want to talk to us, Nikki, and then we'll see if anyone else.
I just wanted to say that I'm speaking on behalf of the Maryland Music Therapy State Task Force and the Maryland Association for Music Therapy, as well as the American Music Therapy Association, that we are in agreement with the language.
Great, thank you very much. And thank you for your willingness to compromise and address this situation. Is there anyone else? Does Susan Adams or Olaremi Dean want to say anything? No? It would be great if we could.
Yes, I would. Hi, thank you, Delegate Kelly. On behalf of the board, as you said, that I cannot, it's not the exact language that the board voted on. However, after our meeting that we had, I think we are pretty much in agreement as well.
Excellent. So we recognize it's not the exact language you voted on, so you can't officially change your position.
Correct.
But it was our intent to meet the spirit of the needs that were addressed. Susan Adams, do you have anything you can add?
I would just add, that, ASHA's happy that we've been able to come to an agreement on the language. And I wanted to clarify that you did mention that they could treat communication disorders. And I think that the way I'm reading the language is that they can't actually treat communication disorders, but can treat individuals who have communication issues.
I'm sorry if I misspoke. I know the words are very important in this instance. I'm reading the same language you're reading. It's just 8:30 in the morning and my coffee is still full. But it's a very delicately worded agreement and we will absolutely stick with the words in front of us.
Great. And thank you, Delegate Kelly, for all of your work in bringing everybody to the table.
Absolutely. So with that, do we have any questions from members or does anybody want to move the amendment?
Move the amendment.
Second.
Moved and seconded. Any further discussion on the amendment? Oh, sorry, I'm having a difficult time again with there's so many hands up. Oh, it looks like Delegate Carlson and Delegate Krebs have their hands up.
Yeah, just two.
Go ahead.
Just two hands. I want
wanted to thank you and for working on this language. And I think this language is really clear that a music therapist can work with someone, with a person who has a communication disorder, but not directly treating the communication disorder, perhaps as part of a team, helping that person be more functional. So I think this is really artful language, and I support it.
Excellent. Thank you. Delegate Krebs.
Thank you, Madam Chair. I don't have the artful language, so I haven't had time to look at this because I haven't seen the language. So I'm just going to be a no until I get to see it. I want to see what I'm voting on. I just haven't.
Is there another email address I can send it to? Because it was
No,
sent.
don't worry about it right now. I just can't look that quick and make these decisions. We've looked all over. My aid's been looking. We can't find it. So you can get back to me. For now, I'm just going to no until I see the language. I just don't like to make decisions when I can't see stuff.
Can we perhaps have an abstain or a non-vote?
Abstain, whatever you want to do.
No?
I just cannot vote for it until I get to see language without 30 seconds notice. And
it did get emailed around yesterday, but we will have you not voting on this and maybe make sure to reach out to me later today after you've looked at it, if you have any issues with it. I think it's the language was crafted very carefully with all the stakeholders in mind.
I appreciate that. I appreciate it, but I'd like to see it. Okay, thank you.
Yeah, I understand the timing issue. We just want to make, this has been waiting for a few weeks while we worked together to find this language. So we can't afford to hold this up further. It needs to be on a voting list today so that we can be done with this and not have this all over again next year. Okay, so with that, all in favor of the amendment, say aye.
Delegate Lewis and Delegate Riley.
Oh, there's more hands up. Okay, Delegate Lewis. Sorry, I tried to open up the language to read it to Delegate Krebs, and therefore I closed my little hands there. Delegate Lewis.
Thank you, Madam Chair. And I encourage you to have a little bit of coffee while I'm talking.
Thank you.
So thank you to all the members and stakeholders. I just wondered, Madam Chair, if it might be possible, if it would help the members gathered here, use this share screen function and throw up the amendment so we can all see it together in real time. Might give us a chance to immerse ourselves a little bit and give, it might be helpful.
Okay. That's a great idea. Okay, hold on. This is the packet that was sent out by Lisa. So this is the amendment in the chairman's name. There's two parts to the amendment. Let's see. Okay, so we have, hold on. Lisa, where should I focus here? Except in this part here?
Yeah, the new subsection D is, and this is about representations to the public, and it would prohibit the licensed music therapist from representing to the public that they are authorized to treat a communication disorder, but it specifies that that language cannot be construed to prohibit them from representing to the public that they may work with a client with communication disorder and address communication skills. And then if you move down to Amendment 3, there was some language already in the bill about collaborating with the speech language pathologist and audiologist on communication disorders. And that language, we were just clarifying that in that collaborative process, the music therapist would be able to work with the client and address the communication skills.
So now that we have the language literally right in front of us, great suggestion, Delegate Lewis. I love technology. Do we have questions from members? I see Delegate Riley.
Okay, thank you, Madam Chair. Yes, my easy question, or I think simple question, would be, so this amendment we put on in the House. Now, do the senators agree with this as well? So it's going to not have to get stuck in conference and all that?
Great question. Yes, the Senate is waiting for us to come up with this language, and then they will adopt it on the House bill that's over there as well.
Excellent. Thank you.
Yeah, and I have shared it with the EHE Council, so they do have the language.
Any more questions from any members? If not, the amendment has been moved and seconded. So all in favor say aye, and anyone who's opposed to the amendment, put your hand up. I see no hands up. Krebs raised her hand. Delegate Krebs, you're going to be opposed to the amendment?
No, it's just a question in general, and it's not just, I don't know if it's on the amendment or on the whole bill, but with the amendment, how, I always get concerned about limiting occupations for people that they now can do. Would this in any way limit, I mean, so many times we've caused so many people to be licensed. The rest of the country is moving in the opposite direction, getting rid of licensure for people so there's not barriers to employment. And I'm always concerned about barriers to employment with licensure that is not necessarily health and safety risk, which I don't think that this is. It doesn't mean you shouldn't be accredited, but how would this limit someone that's in this business that maybe doesn't want to get a music therapy license? But you know what I'm saying? Do you understand what I'm saying?
Yeah, I think this is actually a question we discussed the first time this bill came around, when we talked about the specifics and the need for a treatment plan. But Nikki, did you want to add to that, since the association is in strong support of this?
Yeah, the only thing that is limiting is it's recognizing that music therapy is a profession. It's not limiting people from using music in a therapeutic manner. It's not limiting people who are volunteers who want to play at the bedside. It's not limiting any of that. We make it very clear that we don't own music. The only thing that it would limit is them saying that they are practicing music therapy, because music therapy is a profession. We do have board certification. There is clinical and education training requirements. So they cannot say that they are practicing music therapy and present themselves as music therapists, but they can certainly play music for people, and that is not limiting this at all.
I understand, but could someone go in and still get paid to do a similar type of an event?
There are therapeutic musicians that are paid. There are music thanatologists that are a profession that are paid. So this in no way limits them practicing. It just means that they can't say that they're practicing music therapy. They can't be paid as a music therapist unless they're licensed as a music therapist. They can be a music thanatologist, they can be a therapeutic musician, they can be a volunteer, they can be an entertainer in nursing homes. They can do all of that and be paid. They just can't say that they're being a music therapist. They have to call themselves what they are, because they're not providing a treatment
Can
plan.
you clarify for me that the second, so that they could be a therapeutic musician or they could be a music, what was that second word, and say it slowly because it's early?
Music thanatologists, and so you see them a lot in hospices and in nursing homes and that kind of stuff. And it is a profession, and they can call themselves a music thanatologist, which is what they are. But that is different from the practice of music therapy. And so, when we're looking at a music therapist, there are 1,200 clinical hours. They have to have at least a bachelor's degree. They have to be board certified. They have to have an assessment. They have to do a treatment plan. They have to do contact notes and progress notes and discharge summaries and ongoing assessments. So it's very specific, but that this is not limiting the practice of anybody who wants to use music in their practice. Even a social worker who plays songs in their session, they can absolutely do that. And we're not going to say that they can't do that, but they can't call it music therapy.
I understand. And it's just, again, if it's a philosophical difference, around the country, they're literally moving away from licensing these things because there's so many barriers for people that need employment and want to be employed. And unless it's a health and safety issue, there are many, many occupations that we don't license that are still occupations because they're not health and safety. And it's just an issue. I don't believe this is a health and safety issue. Doesn't mean you're not a professional. Doesn't mean you can't be accredited by a certain group and have that accreditation. But when you require licensure or you can't practice something, you're putting barriers up. And one thing I've been trying with, especially with people that are underserved, we want to remove barriers from licensing versus putting more barriers up. And I just see it as a it's not necessary. I'd rather be moving to take some of these things away. So it's just a philosophical thing about barriers. And I think we have more occupational licensing in Maryland probably than any other state. We license things that no one else licensed. I think it's just the wrong direction. So I'm sorry philosophically, I just disagree with the licensing. So that's my.
Okay, I would like to just have a minute of discussion on the reason why we think licensure is important, in addition to recognizing, recognizing that music therapy is a profession. This language that we are adding in, the amendment that we worked really hard with the speech language pathologists to navigate, is precisely because, as I understand it, and please, any of the experts, raise your hand and let me know, that someone who's trained as a music therapist and in the future would be licensed under this bill as a music therapist is someone who is then well equipped to work in partnership with a speech language pathologist to treat a person with a communication disorder. So they're not doing the direct treatment, but they may work with clients who have that, or any other of the challenges, and that they're going to have a treatment plan in place, right? And that's very important. We don't want people misrepresenting to the public that they have the skills and training necessary to develop and follow through on a treatment plan for a number of the issues that a music therapist might be working on in partnership or collaboratively with speech language pathologists or otherwise. If they don't meet those qualifications, if you just willy-nilly randomly develop a treatment plan and say you know what you're doing, without the structure of licensure, there may be health implications for that. So that would be my way of addressing that. Delegate Bandari.
Yeah, thank you so much. I really like this bill, and this music therapy is an established health professions. This helps within therapeutical relationship to address physical, emotional, cognitive, and social needs of individual. So it is good bill.
Okay. Any other comments? Sounds like
Delegate Kelly, can I respond?
Yes, please.
I know the full screen is on, so it's hard to see everybody. I just wanted to say that music therapy as a profession actually was born out of incidents of harm with World War II veterans. And so when they had come back from war and the doctors had seen how well they responded to music, they realized very quickly that the musicians that they were bringing in were not equipped to treat, what they knew of then as shell shock, as PTSD. So it was actually a profession that was born out of harm, but also in Maryland, there are incidents where people are misrepresenting. And just one example is that somebody was representing themselves as a music therapist in the NICU, the University of Maryland, and going in and playing live music without training. And I know this because it was my client. And she agreed to it because I was treating her other daughter. And so when she heard, oh yeah, music therapy, then yes, absolutely, I want that for my child in the NICU, but it was not a music therapist. So there are incidents where there are most vulnerable populations. I mean, there is just so much that can happen as far as live music in an isolate with, neurons and with, things that are happening in the brain and developing brains that can be harmful if you don't know what you're doing. But also I've had patients in hospice where the same song that was their favorite song when they were 50 now causes agitation. And it's not necessarily because of the song, but it's because of the musical elements. And so somebody who is not trained in knowing which musical elements to remove in order to maintain contact with somebody who has advanced Parkinson's, is no longer able to communicate, then that is an instance of harm. And again, it's same song, but different process in the disease, process that needs to be adapted in the moment and used differently in order to decrease agitation. So I just wanted to speak to those incidents of potential harm and the training that music therapists have when we are dealing with our most vulnerable populations.
Thank you for that. I appreciate it. I'm sure the committee appreciates it. I don't remember if the bill has been moved and seconded as amended. Does anybody? It has. I'm seeing it.
Move the bill as amended.
Second.
Moved and seconded. Any further discussion from the committee on this? I don't see any hands. So I'm going to call the vote. All in favor say aye. Anyone who's opposed, raise your hand. It looks like Delegate Krebs is going to be a no for philosophical reasons against licensure. And Delegate Saab is going to be a no as well. Okay. And anybody else? We're good. Okay, so the bill passes as amended. Thank you to everybody. We're going to move on, and I'm supposed to be in public health. I don't know if anyone else is also in 3 minutes, but House Bill 1032. This is a bill we were going to discuss. So let's get folks in from the waiting room, and we will have a very brief discussion on this since everybody has to leave to go to public health. Tyler, can you remind us what House, before Tyler reminds us, let me just say that this is a bill that, we're going to discuss this. We're going to ask questions if we have them. We're not voting on it. What we're trying to do is figure out what we can do over the interim to get us closer to a place where people are in agreement with this. So Tyler.
Bill 1032, the current law says that a certified nurse midwife working with a patient who has had previous uterine surgery, including a cesarean section, also known as a C-section, shall transfer care to a healthcare practitioner. And if it's a new patient, they will not establish care with that patient. If the bill is enacted, then a certified nurse midwife shall consult with the healthcare practitioner and document their recommendations, as well as document the conversation with the patient if the patient had a cesarean section that was performed at least 18 months ago and resulted in a confirmed low transverse incision, which is one and the most common route for performing a C-section.
Okay, thank you for that. So I don't really know where to start here. I think we brought some
Madam Chair?
stakeholders. Let's start with Delegate Collison. Perfect.
Thank you. Thank you. And I need coffee too. First of all, I want to thank you for having this conversation. And I just wanted to explain why I was bringing this bill at this time. And we have seen and experienced and learned more about midwifery over the last few years. And I believe that, what we've seen is that it is an incredibly viable and good option for families who choose it. And we wanted we want to open it to as many women. We want to open that choice to as many women for whom it can possibly be. And we understand the reservations around the increased risks the potential increased risks when there is a C-section, previous C-section, but we believe in the bill we've put the enough guardrails in to say this decision has to be really informed. The woman and her family need to know all, what their options are, and then it becomes their informed choice. So with that, I think, we're willing to work with other stakeholders over the interim to see if we can get to a place where folks would feel comfortable with this option being offered.
It looks like Delegate Saab has a question. Go ahead.
Thank you, Madam Chairman. Can you just, I guess, repeat the option again? What would they do? I'm sorry, I missed it and I haven't seen the bill. I'm on my phone. Just quickly, what is this bill
And we
suggesting?
can Delegate Collison, if you want, call on any of the stakeholders to bring them into the conversation. Go ahead, Bonnie.
Looking, I think Caitlin McDonough, if you would want to explain to the delegate.
Sure, and I'm happy to explain the bill and kind of, I think, the options that we've been kind of trying to continue the conversation since what we heard at the hearing. The bill as it stands, as introduced and as it stands now would, right now, a licensed direct entry midwife who primarily is seeing patients out of institution. I think that's an important element. Generally, it's going to be a home birth situation. Cannot see any women who've had a previous C-section. This bill would allow you to see a woman who's had a single previous C-section at least 18 months prior to the anticipated due date for the next baby, and who's had what we would consider a low risk incision. So that's going to be a low line transverse incision, which is generally less likely to rupture. and we pulled these elements, these restrictions, they're similar to what we see in other states, somewhat restrictive, more restrictive than some states and about the same as others. After sitting through the hearing and kind of hearing the Hospital Association and from ACOG and AAP, and I think some of the concerns from the opposition, I think in conversations with the sponsor and Delegate Kelly, what we thought is if we need some more time to take a look at the issue and kind of current practice in our state and other states, I think it was Jennifer from the Hospital Association who suggested that the appropriate body to take a look at it would be the Licensed Direct Entry Midwife Advisory Committee, which this committee established when they passed licensure for these midwives in 2015. And that body is housed within the Board of Nursing. It has a couple different stakeholders. It includes licensed direct entry midwives. It includes certified nurse midwives who currently can see women who've had previous C-sections in and out of institution setting. It includes a representative from the Hospital Association who I believe at least currently is an obstetrician. So we thought that would be a good kind of body to kind of house the discussion over the interim, and then maybe we can gather a little more information and work on it for next year. I will note, I don't know how much more to amend the bill. I'm kind of like, as a specific amendment, I do think there's at some point, there's a policy decision to be made whether you're going to allow this to occur in or out of hospitals. I would note that I think Maryland policy is already allowing it to occur out of hospitals with some practitioners, just not these particular practitioners. So I'm happy to answer any more questions. I was just trying to kind of lay out where I think we are right now.
Thank you for that. And let me remind the members that if you have to go to Delegate Peña-Melnick's Public Health Subcommittee, feel free to go. This is just a conversation. We're going to figure out what to do to move this bill forward in the interim. So please go ahead and join Delegate Peña-Melnick, who is waiting to go live for you guys. So I appreciate it. Members who are staying here, who are not on Public Health, can stay here and ask questions of the stakeholders, which it looks like Delegate Krebs has a question.
Thank you. And I appreciate the bill, and I think it's long overdue. But I also appreciate the Maryland Hospital Association's concerns about getting some of the results of bad decisions. So I would support the bill today if I had the choice, but I would suggest over the interim, many states are doing this. And what are they doing to make sure that the hospitals aren't stuck with the a bad outcome possibly and the liability that's involved with that? Because that's a true thing that happened. That's why they're concerned about it. So I hope we come to a resolution for next year, because I think our constituents want more access to this, and I certainly would rather give more access than less, but we do have a problem that needs to be solved to satisfy the Hospital Association. So hopefully we can look to the states and just say, hey, what are they doing that's making their hospitals feel more comfortable with this? But I hope we find a solution, because I think we should open the access.
Thank you, Delegate Krebs. And then I see Jennifer Witten is here from the Hospital Association, and Pam Casemeyer is here. Is there anything else you guys wanted to add to this conversation?
Thank you, everyone, for coming. If you could just be patient.
Sorry, I've got two meetings right now. Anything else to add to this? Are we comfortable with the sort of path forward that Caitlin laid out?
Yeah, thank you, Chair Kelly. Appreciate that, and appreciate the committee and all the stakeholders involved. I think that's right. I think our recommendation would be to work with this advisory group established, as Caitlin shared. There's a number of experts sort of around the table. And I just think it's important that council knows that although we are concerned with some of the liability implications, I think we're just really more concerned around mother and baby safety. So want to really just kind of work through that. I think, having some more data available, looking at other states' experiences. We do have an OB specialist that's on that advisory committee, and he even had some suggestions on certain consultations who you should be meeting with, other conditions and considerations. And so I do think this is worth contemplating and making sure we're making the right policy decisions. So we're committed to that process. And I think that group will be very insightful in terms of recommendations.
Thank you for that. Oh, go ahead, Pam.
No, and Jen said it well. I don't think ACOG has anything else to say. It's just a lot of patient safety issues, and it isn't even just tied to this particular type of provider. VBAC at home is a very, very varied, challenging clinical management issue if things go bad. And so the clinical thing, and we agree with what Jen said, that the committee looking at this may be the best place to do that.
Excellent. Well, at least we're all on the same page on that. So I appreciate it. Anything else from members of the committee before I release everybody so we can get over to Jocelyn's subcommittee? I see no hands. Anything else you'd like to add, Delegate Cullison?
No, just thank you and look forward to working on this over the interim.
Great. Thank you so much. Bye-bye.